my learned colleagues and audience. Welcome to my podcast. A small introduction about me. I am Dr. Subhamoy Chatterjee from Bardwan, West Bengal. I am a senior consultant physician, critical care specialist, and diabetologist. And I am attached to Bardwan Critical Care Unit Hospital as a co-director and in charge of ICU. And I am the founder secretary of Bardwan Cardiologist and Diabetologist Association. So without wasting much time, let us go straight to our today's discussion, which is about a case of diabetes with established cardiovascular disease. Now, we will start with one imaginary patient, maybe named AB, who is a 53-year-old corporate executive diagnosed with diabetes 6 months back. When he came for routine checkup, he complained of weakness. His family history was positive for hypertension and myocardial infarction. He is a heavy smoker for almost 30 years. He quit smoking 5 years back and has been trying to lead a healthier lifestyle. He has history of previous MI 3 years back. His physical examination reveals the gross examination, weight of 92 kg, height of 5 feet 8 inches, which put his BMI to 30.7. That means he is obese. And his blood pressure is 140 over 90 millimeter of mercury. His laboratory evaluation reveals his HbA1c as 8.4%, LDLC of 137 milligram per dl and HDLC 37 milligram per dl, and serum triglyceride 156 milligram per dl. Renal function test EGFR 65, that means he has CKD, stage 2 progressing to probably stage 3 also, and USER is 50. His drug history: metformin 1 gram twice daily, telmisartan 40 milligram once daily, atorvastatin 10 milligram once daily, amlodipine 5 milligram once daily, and aspirin 81 milligram once daily, clopidogrel 75 milligram once daily. So this is the profile of our patient. Now the question is the further management of the patient. If we consider our today's approach, like what is called classically the patient-centric approach, then this patient has to be managed for diabetes, of course, but along with that, the CV protection, microvascular protection, weight reduction, reach glycemic goal with no hypoglycemic event as far as possible, and convenient dose schedule for the patient. As because he is a busy executive, convenient dose schedule is also necessary. Now, primary consideration amongst all these is cardio protection, of course, because he has a previous MI, and to optimize glycemic control for further CV risk reduction and to address any weight related, that means weight gain issues, and more so and better weight loss. So now the question comes, with his present medication, what can be done else, because his HbA1c is also high, and with other factors like LDLC is high and all. So here, according to the international guidelines as well as our national guideline, if we add one SGLT2 inhibitor with a DPP4 inhibitor combination, the benefits received will be a cardio-renal protection as a whole, which is popularly now called actually the diabetic cardio-renal metabolic compendium, that is the timeline of diabetes along with other complications of cardiac and renal complications. So that is the timeline. In the timeline, he is already has progressed. So cardio-renal protection should be there for the benefit of the patient. A simple regime, because we are giving just once daily fixed dose combination, and early and durable achievement of glycemic goal that is more than 1% with a, if it is a EMPA-LINA, which is the most preferable combination now, along with other SGLT2 inhibitor and DPP4 inhibitors. And if it is a 25 milligram, 5 milligram combination of EMPA-LINA, then the achievement of glycemic goal in terms of HbA1c is more than 1%. It has study-based and statistics-based result of weight loss, as well as almost negligible hypoglycemia if the dose can be adjusted judiciously. And for further discussion, we can tell that cardiovascular disease actually is a leading cause of morbidity and mortality in adults with type 2 diabetes, with its onset estimated to occur actually 12 to 15 years earlier in people with type 2 diabetes. The excess risk for atherosclerotic cardiovascular disease in patients with type 2 diabetes has been estimated to be at least twice that of those without diabetes. Now, Framingham offspring study suggested two-thirds of the patients of diabetes mellitus have subclinical CVD. Actually, these two, that is diabetes and cardiovascular disease, they are called the common soil disease. That means both actually exist in the same soil and share the same pathophysiology. And diabetes mellitus increases the risk of subclinical CVD, and that is the reason by 4.3 fold, where odds ratio is 4.33 with a significant p-value. And subclinical cardiovascular disease increases the risk of CV event by twice at least, and the vascular wall in patients with diabetes is well known to have advanced atherosclerosis, and that is also very early, has very early occurrence in type 2 diabetes patient. And the EMPA-HEART study, effect of empagliflozin on cardiac structure, function, and circulating biomarker in patients with type 2 diabetes showed that actually empagliflozin resulted in early and significant reduction in left ventricular mass regression as detected by cardiac magnetic resonance imaging, MRI, and also suggests the reverse cardiac remodeling, and which is a possible contributor to the cardioprotective effect of SGLT2 inhibitor. 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management began with the EMPA-REG outcome study, which demonstrated significant, I must say huge statistical benefit of empagliflozin for CV mortality by relative risk reduction of 38% of CV events, as well as major adverse cardiovascular events in type 2 diabetes and CV disease in primary as well as secondary outcome. And all types of CV deaths were reduced with empagliflozin. More prominent absolute benefits were observed for heart failure related deaths and sudden deaths. And the post hoc analysis of EMPA-REG demonstrated consistent CV mortality benefit, and irrespective of prior CV event, that is MI or stroke, heart failure burden, CKD, baseline HbA1c level, control of multiple CV risk factors, or background use of metformin. So this is an independent molecule which actually reduces the CV risk, and more so after EMPA-REG, two major studies has been published just earlier yesterday. One is EMPEROR reduced and another is EMPEROR preserved, and both have shown very significant statistical benefit in heart failure patients de novo with or without diabetes. So that is an important finding with empagliflozin as a not only as a oral anti-diabetic molecule, but also as molecule which can prevent CV death and heart failure and hospitalization due to heart failure also. And several mechanisms also have been proposed for the CV effects of SGLT2 inhibitors, including osmotic diuresis and natriuresis, leading to blood pressure lowering, decrease in arterial stiffness and vascular resistance, decrease in weight, the decrease in uric acid and oxidative stress. And that is very much, we can actually, by laboratory measures, we can count it also by measuring NT-proBNP, just like when we use ARNI also. So that is a significant effect again on the CV effects in case of a type 2 diabetes patient. And it has also been reported that SGLT2 inhibitors promote reverse cardiac remodeling, improve myocardial energetics and filling condition, reduce alveolar stress and mass, and reduce the blood pressure and arterial stiffness. The EMPA-HEART Cardiolin 6 study again demonstrated that empagliflozin could produce early reverse cardiac remodeling in type 2 diabetes mellitus and a stable coronary artery disease we can offer to the patient. Now for the linagliptin in Carmelina and Carolina trials, linagliptin has also demonstrated its CV and renal safety as a large statistical database. And that is a secondary endpoint of the trials. And the linagliptin versus placebo or active comparator, when added to the standard care in patients with type 2 diabetes, it has, of course, proven and demonstrated CV and renal safety who were at risk of vascular complications, the type 2 diabetes patients. So, EMPA and LINA, if they can be combined together with their added and additive benefits, it available as a first-in-class treatment in SGLT2 inhibitor and DPP4 inhibitor combination group of drugs. And at 24th week, EMPA-LINA 25 and 5 milligram concentration fixed dose showed statistically significant HbA1c reduction of more than 1 and with a mean standard baseline 7.99 with a significant p-value and all. And that is a significant add-on to metformin therapy for diabetes management as well as for managing further complications of cardiac or renal nephrosystem or cardiac and renal safety. And HbA1c decrement by EMPA-LINA 25 and 5 milligram has demonstrated 1.81% HbA1c reduction at HbA1c baseline of more than 8.5 at 24 weeks, which is also very welcome effect for the diabetes management part. So at the end, we can say actually the combination offers a suitable component in strategy to manage diabetes as well as CV and renal protection to achieve the target of HbA1c without hypoglycemia and with a welcoming weight loss, not weight gain. That is another welcoming effect in patients with high baseline HbA1c level, together with cardioprotective as well as renal protective benefit in patients. So that is the end of my today's discussion. Thank you all.